Okay, hi, my name is Eunice Asali. I'm a midwife, a mother, and besides, I'm a teacher of midwifery nursing, and also I am a national secretary for Midwives Association of Kenya. So, besides that, now I'll talk about my pregnancy journey. So, being a midwife, my second baby, actually, I have two children. One of the children would be 18, but the second child is 16 years old. So, when I was giving birth to my child, like any other mother, I had a very nice pregnancy, like very uneventful pregnancy. Then I had a planned cesarean section because the first pregnancy had been CS, and because of the first pregnancy being a cesarean section, the second one came too soon. So therefore, I had to have a planned cesarean section, and it went well. We planned to have the CS at a major referral hospital, and while I went there after cesarean section, during recovery period is when I noted that I'm bleeding. So because when I woke up, I found myself in warm fluid, like I was lying in a lot of fluids. So when I talked to the nurse who was there, I was like, I think I'm bleeding. So the nurse told me, well, I've been seeing your blood pressure go down, and I didn't know it was because you are bleeding. So when she opened the sheet, the blood flowed down and it wasn't clotting at all. So she called the doctors who were around to come and examine me. And my doctor had already left. So they called him, who eventually came. But then when I had one of the doctors mention that it seems the Eunice is having DIC. DIC is a condition called disseminated intravascular coagulation, and it is a condition that where the blood does not clot adequately, and therefore you bleed a lot without the blood clotting. And therefore, when I had that, the first thought was, I'm going to die. And because of that, I requested, can I have my baby before I die? Can I just see my baby and, of course, breastfeed and just look at my baby, because this is a child who came out and is already in nursery. I haven't even seen him. So that was my first thought. The other thought was like, where is my husband? So those two things I kept on requesting. So when the doctor came and started doing maneuvers like compression of the uterus, remember this is a fresh uterus that has just been cut, and it has to be pressed so that it's able to contract effectively. So that had to be done. Then of course there was a drug that was injected directly on the uterus. So that drug is called PDF2. The prostaglandin, I think, is one of the drugs that could have almost killed me at that time, because when I collapsed immediately. So by the time I woke up, I realized a lot had been going on. Like, for example, the bed I was in now was, the head was down and the legs are up, just to help the blood to flow in the head. But I thank God I was in a place that was able to support that effectively. And the doctor I was with actually stayed on with me, monitoring the blood and monitoring me throughout the process. So it was a very scary moment. In fact, I hadn't gone to do my midwifery masters at the time. So after recovering and all that is when now I decided to go and do my masters in midwifery. And I really focused on postpartum hemorrhage as a key factor. Then after that, I joined the Midwives Association of Kenya, and I noted that so many women in Kenya were dying from postpartum hemorrhage, and I became the biggest advocate for postpartum hemorrhage. So I've been doing, even for the association, I've been mobilizing funds, and so that we are able to make sure that all the midwives from all over the country are aware on how to manage postpartum hemorrhage. I've been privileged to work on postpartum hemorrhage, on the guideline, maternal newborn guidelines within the country and policies. And because of that, I've been exposed a lot to the new things and also the new bundles approach. And hence, have made sure that within the association we are doing continuous professional development for all the midwives from all over the country. We want to make sure that every midwife, every healthcare professional that attends to a woman, especially during birth, is aware of this particular bundle approach and is able to manage a woman effectively when they have postpartum hemorrhage.
This is a leading cause of maternal mortality. Up to almost 40% of women will die from bleeding after delivery. The causes include, what we call trauma during delivery. A number of patients believe that they must deliver in a normal way, and sometimes that becomes very catastrophic, in the sense that during delivery, the uterus can rupture. That can lead to massive bleeding, and that can kill a woman. Along the pathway, the pathway can tear, and those tears can bleed, and they can cause a lot of bleeding. Some people, just merely by being pregnant, some of the clotting factors reduce. And others have got conditions like liver issues in pregnancy and high blood pressure issues in pregnancy, which lead to the reduction in the number of clotting factors. This is now the center of our intervention as obstetrician and gynecologists, because it has a drug component in it. And in the country, we are doing a very big campaign to have that every place across the country, especially the northern part of the country where there is a lot of heat. You need what we call heat stable kind of drugs, which can be used to prevent this kind of bleeding.
How are these innovations helping? Have they reached to the grassroots, and are they helping these people, or we are still experiencing more cases of PPH in such regions?
Is among the counties which were very fast to accept this kind of interventions was Makueni. And the statistics show that there are very few or almost to none kind of maternal mortalities arising from postpartum hemorrhage, which is tone related. But I do believe that the statistics we have across the country, most counties have embraced this heat stable capital-C. And therefore, for places like northeastern, Garissa, Mandera, and the rest, the other now next important aspect is the capacity to treat these women, especially considering that there is an issue of access spirit and also embracing the hospital kind of treatment that is needed. So if we crack into reducing home deliveries, then we will make progress, because I do believe Garissa should have the drug, and Mandera should, because this is not a very expensive kind of investment, because these are drugs which are supplied through KEMSA in the country.